Hi, I'm Bob Eckel. I'm one of the co-chairs of the Cardiometabolic Health Congress, and we're in our 17th year and back in Boston this year. It's a great thrill to be back in Boston, Massachusetts for the meeting. Today is our pre-conference, and the title was Maintenance of Cardiometabolic Health in the Older Adult. We've had a series of speakers, and we have two with us right now. One is Dennis Villareal from Baylor College of Medicine. He's a professor of medicine there. And the other is Dena Rifkin. She's from the University of California, San Diego. And they were two of the several speakers we had in the first part of the symposium this afternoon, again, dealing with various aspects of cardiometabolic health maintenance in the older adult. So Dena, let's start with you. You really kind of reviewed the complexities of managing blood pressure in the older adult. And one of the issues that comes up is compliance to medications. And I think, is that a bigger issue in the older adult than it is in the younger adult? And if so, what can we do better to have our patients continue to take their medications?
Sure. So compliance or adherence to therapy, being able to persist with a therapy over time. So there's multiple dimensions to your question, really. So can you pick up the medicine at the pharmacy is step one. That has to do with money. So I'm very honest with my patients. I try to, ask them, do you think you can afford to add a medicine to your regimen? So even before we leave the office, do we think that we can get adherence at the pickup counter? Okay.
Now, VA system, the cost shouldn't be that big of an issue, is it?
It's still $5, and if they don't think it's worth $5, if they don't think that what I've prescribed is worth it, then that can be a real issue. So there's whether it's going to get picked up. So I'm lucky in that my prescriptions are generally inexpensive for my patients. But if I were outside that system, I might have to think differently. And then there's kind of what is the habit that people get into in terms of what medicine they can take and when, right? What is their system? Do they have a pill container? Do they have many of my patients, it's their spouse is their pill system, right? It's the person reminding them to take their medicine. So what system do they live in? What is their cognitive function coming in? So all of that has to be considered when you're changing something for somebody who's older. I almost never prescribe medicine that has to be taken more than once a day or twice. And if it's more than twice a day, it's going to be it's almost a statistical impossibility that they'll be able to take it.
Well, one thing we think about a lot in cardiometabolic medicine, and actually we should think about it in all forms of medicine and treatment of our patients that we see day in and day out, is individualization of therapy. How does an individual impact your decisions on how aggressive to manage their blood pressure, and perhaps even choices in terms of how you manage their blood pressure?
So one example that I give when I'm teaching the medical students often is to understand what somebody's day looks like. If they are a bus driver, then a diuretic may not allow them to continue their job because they're not allowed bathroom breaks or something like that, right? So you need to understand what the person's kind of daily life is before you pick the medicine. And then I try to negotiate with my patients about side effects. And the negotiation that I try to pose is, I want this regimen to end up having almost no side effects for you, right? Almost no side effects, because I want it to be something that you can take for a long time to prevent strokes and heart attacks. And so I want you to come tell me if you have side effects. So diuretics are an easy example to talk about. But sexual side effects are a big deal for a lot of older adults, and they're not going to come talk about that unless I tell them that they should come back and tell me. So I talk about that a lot too.
All right, thank you. Dennis, to you now. One thing we hear a lot about is this obesity paradox, and you mentioned that up front in your talk, but you didn't provide us any more details. Is this a real phenomenon, this obesity paradox in older adults?
It's a bit controversial. There are limitations to the data, considering that weight loss could precede dementia, and therefore it may be a harbinger of something bad. And so people have been concerned that weight loss is harmful in the elderly, but that's not differentiated with regards to its voluntary or involuntary. So voluntary weight loss, we have shown, is not beneficial, but you have to balance the benefits versus the risks, for example, loss of bone mineral density and muscle mass.
I know the data are somewhat controversial, but I think about it mostly in hospitalized patients with heart failure or other cardiovascular conditions who are in the CCU or ICU who then get discharged. And I think the observational data suggests that being a bit overweight or obese may be an advantage. How do you relate to that data in terms of how you deal with your patients in the clinic going forward?
Yeah, in some respects, it may be advantageous. For example, they're in the hospital and they would develop less pressure sores because they have excess adipose that can protect them. But we know that the ideal body mass index for the elderly is higher than in the young. People have shown that 27 might be the BMI, so they can be a little bit overweight. So the interventions that I've shown in my presentation is people that have body mass index of 30 at least, so we won't do weight loss when they are less obese.
Now, one thing that comes up clinically, and I'll relate to my own personal practice, I'm an endocrinologist, but my clinic was in the heart center, so I had a joint appointment. But to cut to the chase, often I'd see a 75 or 80-year-old woman or man who in fact needs to lose weight, but ultimately the behavior change, and I mentioned that a little bit during our time on the podium, ultimately is a challenge. Now, then I think about things like the obesity paradox, and I think about outcomes. How do we individualize who is importantly needing to lose weight, who's in the 75 to 85 age category?
Yes, so the guidelines from the American Society of Nutrition and the Obesity Society indicates that weight loss is indicated for elderly who are obese who have medical complications or functional complications that can benefit with weight loss. So in our study, for example, they had to demonstrate some impairment of physical function. They had evidence of physical frailty for them to be enrolled in our study of weight loss therapy. So for a person you mentioned that does not have metabolic syndrome, diabetes, and he may be a metabolically healthy older adult with obesity, and there's some concept of selected survival also. As we know, obesity shortens survival. So people who escape the medical complications of obesity when they're young and they survive that in the elderly, they might be a little bit protected against metabolic complications, but I would say not necessarily on functional impairments, because again, with the need for more muscle mass to carry their body weight, and with aging there is decrease in muscle mass, there's decrease in rate of muscle protein synthesis, so sarcopenia, and then you have the sarcopenic obesity, which is also a particular syndrome that is being recognized. And sarcopenic obesity is defined by decreased muscle mass and decreased muscle strength. So you don't have sarcopenic obesity if you have decreased muscle mass, but you have normal muscle strength or function. So that you have to have impairments of function to benefit from weight loss, for example.
All right, well, Dr. Williamson talked about frailty, and I think that's something we all don't adequately assess in the clinic, and calculating this frailty index is complicated, but it relates to many things we do in the older population, assessing frailty and outcomes that relate to that. I have a question now that's bi-directional, so it's going to both of you. In your guidelines, you, like everybody else, talks about sodium restriction, or at least, thresholds of sodium intake. And back to blood pressure in the older adult, in terms of sodium restriction, how important is that in an 80-year-old with a history, say, of a cardiovascular disease event, whose blood pressure is 150 over 60, that big pulse pressure too. So both of you, going to you first, Dena. Sodium restriction and the older adult with hypertension.
It actually, the guidelines generally indicate that sodium restriction may have a more powerful effect in older adults, which it would have a more powerful effect if we could actually affect the effect. If we could affect the behavior, we probably would make a difference. So I do talk to people about their salt intake. In my practice, people are so far off from those targets that we're coming from here to here, not from here to here to the target.
And how successful are you in modifying sodium intake? Do you assess this with urinary sodiums or anything like that?
I don't. I think the suggestion is that by and large, physicians are not very effective
Yeah.
in modifying sodium intake. So I never put out that diet and exercise recommend. Dr. Villareal may be ready to shoot me over here, but I never put out the diet and exercise recommendation by itself for a patient with high blood pressure.
I'll put up a shield here.
Yeah,
Sure.
I say, I want you to try this while we treat your blood pressure.
Okay, now sodium intake 2,300 milligrams, I think is what you said. So the issue comes up is you mentioned water intake, say 2 to 4 liters a day. And that's an interesting area in its own right. But, people who stay hydrated may not be sometimes taking enough sodium in, and they may have orthostasis and things like that. How does that impact your management in terms of salt restriction?
Well, these are general guidelines, so it needs to be individualized.
Always.
And this is more in the context of prevention, maintaining healthy lifestyle. For when you see a very frail elderly, now the priorities change. We want quality of life, and we don't want them to become malnourished by restricting too much. So it has to be individualized. If a patient has hypertension, then we wouldn't want added salt and would like to limit to 2,300 milligrams if possible, as long as it doesn't translate to anorexia and malnutrition.
Again, do you find that patients sometimes, to both of you again, in terms of blood pressure management, is orthostatic hypotension often assessed in the clinic, number one? And number two, if a patient is orthostatic, how does that change your management strategy? Dena, to you first on that.
Yeah, if they're symptomatically orthostatic, and by that I don't mean that I am necessarily measuring. We do not systematically measure orthostasis.
Important though, isn't it?
It is important.
Yeah.
When we first instituted the AHA blood pressure protocol, I was also having the staff measure orthostatics in every patient, and we had total mutiny on that front. So we went back to doing the AHA protocol. By symptomatic orthostasis, I mean I ask people, are you dizzy when are you lightheaded when you stand up, right? And that does temper my aggressiveness a little bit. The data on orthostasis from SPRINT there was more orthostasis in the intensive arm, but the difference from injurious falls and so forth was not as marked. So, what we worry about orthostasis because we're worried about falls, or are we worried about orthostasis because we're worried that people will be afraid to exercise? And I think those are different questions, right? So the person who's symptomatic, I do worry about them. The person who's somehow had orthostatics measured and is mildly orthostatic but asymptomatic, I worry less.
Now, to clarify for me, I just don't recall in SPRINT, were orthostatic blood pressures measured in SPRINT?
They were measured in SPRINT.
Measured.
Yes, as part of the, it didn't change the management.
Okay.
It didn't change the randomization goal, but they were checked, yes.
Okay, that's something, again, I think we can really encourage our healthcare providers to be doing in the clinic. Back to you, Dennis, again, to close out here now, in terms of orthostasis in the older adult. Does that change your approach any?
Yeah, of course. If they're orthostatic, then we review polypharmacy, try to reduce medications, and we look for treatable causes. And like you endocrinologists, look for adrenal insufficiency sometimes. Right? If they're dehydrated, I see they might getting diuretics and they're overtreated, of course, yes.
Okay, good. Well, I want to thank Dena and Dennis for being with us today to kind of sum up the time we spent on the podium a few minutes ago, and hopefully this will be educational to you out there. Again, we're at the 17th Annual Cardiometabolic Health Congress in Boston, and I'm Bob Eckel with my colleagues beside me. Thank you very much. Bye.